Welcome to SOLTI Controversies. I am Benedetta Conte. I am a medical oncologist working in Italy at the University of Piemonte Orientale in Novara.
And I'm Rodrigo Sánchez Bayona. I'm a medical oncologist working in Hospital Universitario 12 de Octubre in Madrid, Spain.
So let's start with this talk. We are going to comment the results from this year in HER2 positive breast cancer, where now we have a lot of therapeutic options, both in the early and the metastatic setting. I think we can start with the early stage setting. We have two trials with trastuzumab deruxtecan, one positioning it in the neoadjuvant setting and the other one in the high risk adjuvant setting in patients not achieving pathological complete response. So, Rodrigo, which patient would you select for neoadjuvant trastuzumab deruxtecan, and which ones would you select for reserving the trastuzumab deruxtecan if they do not achieve PCR?
Yeah, certainly I think that's probably the key question for this year. We saw the results in the ESMO Congress for both trials, the GB11 with neoadjuvant trastuzumab deruxtecan randomized versus chemotherapy and dual anti-HER2 blockade. And also we have the GB05 with the adjuvant strategy for patients with residual disease after chemo and anti-HER2 blockade. So starting with the GB11, I think that the main reason for choosing a neoadjuvant strategy is that the goal of achieving a pathological complete response, a PCR, in HER2 positive, it has a clear prognostic impact, right? So it's like going for a one-shot strategy. If you can select those patients who will clearly get a PCR, probably you can feel more comfortable thinking that you are curing more patients. And it is like a pro-con when both trials have its advantages and disadvantages. I think GB11, the main advantage is it's a shorter course of TDXD, just 4 cycles, that meaning a lesser incidence of ILD, which honestly I think it's very important to balance toxicity, specifically in a curative setting. And the increase in PCR was clearly statistical and clinically meaningful. Maybe not so astonishing that we were expecting from the data we have from metastatic disease. But at the end of the day, if you have a patient with very locally advanced disease and even patients with inflammatory breast cancer that were allowed to be enrolled in the trial, I think that would be a good strategy. On the other hand, I think that the DB05 strategy and reserving this somehow escalating strategy with TDXD, 14 cycles, higher incidence of ILD, but you can make sure that those patients, you can rescue somehow those patients that despite an optimal polychemotherapy plus dual anti-HER2 blockade, despite not including anthracycline-free strategies, you somehow rescue those patients, and the benefit, both in terms of statistical and clinically meaningful, I think were more convincing, right?
Yeah.
I don't know if you would prefer one strategy or another.
I mean, it's really intriguing to have the possibility to do only 4 cycles of TDXD in the neoadjuvant setting, because I think that the tolerability it's much better, even compared to the full course of polychemotherapy. Still, I'm not sure which kind of treatment to prescribe in those patients not achieving PCR following this schema. So TDXD followed by chemo plus trastuzumab plus pertuzumab. Which do you think that prescribing TDXD in the adjuvant setting will still work? Will you shift to anthracycline-based chemotherapy? What will be your choice?
Yeah, exactly. That's a good question, because nowadays the honest answer would be we don't know, because we don't have the evidence, and the trial did not address that. In the DB11, those patients that did not achieve a PCR TDM1 was recommended, of course, it's the standard of care, despite that not every patient in the DB11 received TDM1, and we currently know it has an overall survival impact, so it's clearly a standard of care. But on the contrary, what are we going to do if patients already receive TDXD in the neoadjuvant setting? What would be the preferred options? I would say it depends on the type of residual disease. If it's an RCB of 1, maybe we can go for TDM1. If it's an RCB 2 or 3, honestly, if they don't have received prior anthracyclines, I think that would be the most conservative option. But again, we don't know. Then depends also if the residual disease is only in the nodal sampling. It's difficult.
I mean, what I'm worried about is that TDXD alone was associated with fewer pathological complete responses. So in those patients not achieving pathological complete response, I have the feeling that these patients are going to need more chemo in the adjuvant setting. But as you said, we don't have any data. And another point I'm worried about is, okay, the ILD was incidence was really low in the neoadjuvant setting, the DB11. We still had some toxic death from ILD in the DB05. And patients in both trials were followed through serial CT scans. This is not something we are going to do in the clinical practice, at least in Italy. This is not feasible.
Yeah, in Spain, it's very challenging to perform a CT scan every 6 weeks or even every 9 weeks for patients in curative settings.
Yeah, and I think this is something really concerning because we are still talking about patients who are free from cancer or with a curable cancer.
Indeed. Yeah.
And toxicity does really matter.
But probably that's one of the main reasons that in the comparison arm we saw similar incidence of ILD with patients treated with chemotherapy. Maybe in the taxane arm that we are seeing more ILD than what we expect because we don't perform routinely CT scans. So that's the next question is what's the implication of a grade 1 ILD, asymptomatic, that patient is doing well, and if you would delay surgery for a patient that underwent neoadjuvant strategy and has a grade 1 ILD, because we don't really know, right?
Yeah, totally. And do you think that there is still a subgroup of patients who could receive less chemo, dual anti-HER2 blockade, and skipping trastuzumab deruxtecan in the neoadjuvant setting?
Certainly. I think that what we have learned in the previous years is that with all these new genomic tools like HER2DX, we can really tailor the treatment and avoid to overtreat or under-treatment in this patient, right? Because I think that probably HER2 is like the HER2-positive breast cancer is the paradigm where there is no standard treatment, even in the early or in the advanced disease that we're going to be discussing shortly. But I think that in the early setting, we can really tailor the treatment to avoid polychemotherapy, maybe even avoid chemotherapy. We have the evidence for the FORGAIN trial, right? When you select those very exceptional responders, you can even omit chemo with a mid-term good event-free survival. Let's see what's the long-term follow-up. But certainly, I think that by selecting those patients who have higher chances of achieving a PCR with less chemo, like for example, the ADAPT trial with paclitaxel, trastuzumab, pertuzumab, in just 12 weeks, you have higher chances of achieving a PCR. How can we compare that with TDXD and all these strategies of escalating? In which patients do you consider to do HER2DX?
I mean, I really like the data from the COMPASS trial. So where the biomarker analysis with HER2DX, then it's clear that patients with the HER2DX PCR likelihood score high, medium, have really good PCR rates with just the taxane and the dual anti-HER2 blockade. Especially, I really liked the data in the HR positive, the hormone receptor positive population, because those patients, if they have the PCR score high, they have PCR rates as high as 60%. So I think that these patients probably should be treated with just taxane monotherapy plus dual HER2 blockade. And also, if they are low risk for recurrence, according to HER2DX, I'm not sure that giving more treatment in the adjuvant setting is going to add anything.
Yeah, to have better chances. Do you foresee any patient that may benefit for a chemo-free strategy in the early setting?
I think this is really intriguing, and probably, yes, there is a really HER2-addicted population who could be treated with just dual HER2 blockade. I'm not sure that we're already there with the biomarker selection.
Totally right.
It's really difficult, and probably it's a really small percentage of patients.
No, fully agree, because at the end of the day, what we want to to achieve to avoid this metastatic relapse. So this takes us to the next topic, this advanced disease. This is a very busy scenario. We have witnessed just in less than 1 year, 3 positive trials, phase 3 positive trials in the first line setting. We saw the results of the PATINA trial a year ago in San Antonio. We saw the DB09 with T-DXd pertuzumab in ASCO, and we just saw now in San Antonio the HER2 Climb 05 with tucatinib, right? So how do we select among all these options?
Yeah, that's really a tough question. Of course, the DB09, it's a positive trial, and I have no doubt that there is a substantial proportion of patients who is going to truly benefit from the T-DXd in the first line. I'm not 100% comfortable in giving this option to all patients, because I think that everybody treating patients with breast cancer in their clinical practice, they have seen patients living 10 years, 8 years, 6 years with just the Cleopatra schema and with maintenance treatment with the trastuzumab plus pertuzumab, and this is giving excellent quality of life. This patient can mostly forget that they have metastatic disease. I'm not sure this is going to be the same with trastuzumab deruxtecan because it's far more toxic. So I think that selection here is key. I really like the results from the PATINA trial. Actually, the progression-free survival results with the maintenance with palbociclib, endocrine treatment, and the anti-HER2 treatment are even longer than the PFS results from the DB09. So for the hormone receptor positive population, I will definitely consider the PATINA option. And also the HER2 Climb results, which have just been presented in this San Antonio, are really interesting. I think that the PATINA trial outperformed the results from the HER2 Climb. So for the hormone receptor positive population, the PATINA scheme is my preferred choice. But I also think that adding tucatinib to the anti-HER2 blockade as a maintenance treatment in the hormone receptor negative population could be an option. The real deal here is to find a way to identify the early progressors, the patients who are not going to respond to the first 6-8 cycles of chemo and dual HER2 blockade, who must definitely receive trastuzumab deruxtecan, and we do not have
any tool.
Any tool right now. Probably HER2-DX could give an answer. And now I'm going to give you a question. Patient with hormone receptor positive, HER2 positive metastatic breast cancer, but with brain mets, would you prefer T-DXd, the HER2 Climb schema, or PATINA?
Yeah, I think that's one of the key questions in HER2 positive disease, right? What we know from the trials that the 3 of them enrolled patients with baseline brain mets, stable brain mets, even if the numbers are quite low. The 3 trials demonstrated a clear benefit irrespective of the presence or absence of brain mets. We just saw today that even the PATINA strategy can't prevent or delay the incidence of progression in the CNS. The question is, if talking about primary prophylaxis of brain mets, if a small molecule like a TKI or a CDK4/6 inhibitor maybe has a better penetrance in the blood barrier when it's preserved, or a big molecule like an ADC has the same role, not in terms of intracranial activity, because I think T-DXd, of course, is one of the drugs with the highest intracranial activity. But if the blood barrier, the blood-brain barrier is preserved, what's the role in preventing the incidence of primary prophylaxis of new brain mets? Probably that question still remains unanswered. But I think that if I had a tool that could predict the risk of developing brain mets, and probably HER2-DX can give us some lights on this, I would love to stratify my patients and decide what would be my preferred treatment line based on this risk stratification, but also knowing the risk of developing brain metastases. Fully agree with you that for hormone receptor positive, HER2 positive, I think the PATINA strategy is really good quality of life, oral medication, no alopecia, no risk of ILD. But on the other hand, for example, if the patient has baseline brain mets, I think that T-DXd might be still a bit superior to other options. But again, if the patient prefers an oral medication with no alopecia, maybe better tolerated, I think tucatinib still remains a very good option. So at the end of the day, it's quite difficult to have like a personal algorithm. Honestly, I think it's very important to discuss all these options with the patients and also hear their preferences. I think that oral medication is always a good deal for patients, but maybe there's going to be room for every single option. I think that's the real triumph of precision medicine, right?
Yeah.
To really translate into personalized medicine. How do you would you discuss with your patient? For example, let's imagine you have a young patient with a very early relapse after neoadjuvant anti-HER2 with bone and visceral disease. Would you, and it's a hormone receptor positive, would you go definitely for a patina, or would you prefer the DB09 strategy?
It depends, I think, on how early the relapse is, because if the relapse occurred maybe within 1 year from the last TDM1, for example, let's suppose this patient had received adjuvant TDM1, with the visceral disease and maybe brain mets, I will discuss with her the option of T-DXd in first line, for sure. This will be my preferred option, probably. If the patient has a relapse, not an early relapse, a later relapse, maybe with mainly bone disease, with a hormone receptor positive, HER2 positive disease, I will totally discuss with her the option, the patina option, because I think the quality of life will be preserved, and I'm positive that we can achieve a really long disease control with this approach.
And now that we have all these drugs with very good CNS control disease and very intracranial efficacy, should we start the screening for every patient looking for brain mets, or should we still wait for symptoms to develop, like the current guidelines say? Would you?
I will actually. This is what I'm currently doing in my clinical practice. I prescribe CNS screening for metastatic patients, and in those patients for whom I do feel that they need CTC scans because they are at a high risk of relapse, I do include also in the early stage the CNS CT scan, for sure, because if this will allow me to discuss with the radiotherapist or neurosurgeon a local treatment, I still think that the Cleopatra schema, maybe with adding tucatinib in the maintenance treatment and doing local therapy for the brain mets, I think is still a good option compared maybe to T-DXd in the first line. I think it's something it should be discussed with patients. So it helps keeping more therapeutic options open, I think.
And when you find some asymptomatic CNS foci, do you even consider replacing or delaying local therapies and be replaced by all these super efficacy systemic therapies? Would you see any scenario where this can be applied?
So to prefer the systemic treatment, yeah, I think this could be an option, totally. I'm not sure that in terms of quality of life, toxicity, and disease control, it's necessarily better to prefer the T-DXd or tucatinib as the first option compared to the local regional treatment. I still think that local regional treatment is still a good option for this patient if it's feasible and we can achieve a good disease control.
Good, totally agree. So I think that probably we still have many good options for our patients to come. The median overall survival for HER2 positive has increased a lot. So probably the best is yet to come in HER2 positive. I really enjoyed the conversation.
Me too.
I hope that the audience also enjoyed it. And thank you so much for your attention.
Thank you.